And it's a great pleasure for me to introduce now Professor Roald Havre, who is also a senior consultant at Haukeland University Hospital here in Bergen. He is also affiliated with National Center for Ultrasound and Gastroenterology, and he is considered an expert in contrast-enhanced endoscopic ultrasound. And he has quite a few experiences in how to deal with contrast-enhanced application in this wonderful technique of endoscopic ultrasound. So please, Roald, you are in Gothenburg right now. Are you with us?
Yes, can you hear me?
Yes, I can hear you clearly.
That's good. Yes, I'm directly broadcasting to you from the Nordic EUS meeting in Gothenburg. And we've had the 2 exciting days here. So my task today, and thank you for the invitation to speak about contrast-enhanced EUS. This is something that we have been working with and have some experience with now, but we have not published anything. So I will speak from my experiences, and as you will see from the images and videos I will show you, it's not always perfect and it's sometimes difficult, but I think this is a part of the learning curve. So maybe you will enjoy that too. So first of all, when we do endoscopic ultrasound, we have a much smaller transducer. So we have these small transducers which emit frequencies that are generally higher than the transabdominal ultrasound. On the other hand, we are able to reach, especially perhaps the pancreas, since it's going to be an important target for this talk, from the stomach and from the duodenum in the way that this illustration shows. Of course, when we emit sound from these, the crystals in these arrays are very much smaller. So you can compare it to listening to the treble speakers of your sound instead of listening to your bass speakers. So while the external ultrasound are the bass speakers, these are the treble speakers. So we have to use some more energy, even if we deal with delicate bubbles. The relevant contrast media for EUS is for the most of you, SonoView, which you know well, and is sulfur hexafluoride in a phospholipid shell. There is another relevant contrast medium, that's Sonazoid. It's perfluorobutane in a lipid layer, and it's been available in Japan and South Korea for several years. And for the last 6-7 years, we've also had the possibility to use it in Europe. I'm not going to go into too many details of this. You can use both of them. And perhaps the combination of EUS and contrast is a true love story. There are some challenges we have to know about when we deal with EUS and contrast agents. When we apply transcutaneous application, we use frequencies around 1 to 6 megahertz, and the contrast media are optimized to deal with these frequencies. And of course, we use the second harmonic frequency when we listen to the signals from the bubbles. And very often we can use half or only a quarter of a vial intravenously and have a very good examination with external ultrasound. And the patient is awake. We can induce breath hold and we can reduce movement if we need that. On the EUS application, it's a bit different. We use higher fundamental frequency of 7.5 to maybe up to 15 megahertz, or in this range. And maybe these contrast agents are not so optimized for this frequency. And we must also apply a little higher mechanical index than from the outside. So we can't just copy the settings from the external ultrasound and use it for EUS. We therefore have to kind of compensate by using a higher dose of contrast medium. Maybe you have to use a full vial, or you have to use half a vial for one examination. And we see that in the near field, we also have trouble with some bubble destruction. And we also have a more shallow field of view, usually with the EUS. We use sedation, so cooperation with the patient, holding breath and so on is much harder to do. And we also, with the pancreas especially, it's very close to the cardiac movements, so that we will have constant movement. We also have to think about when we use contrast or if you use repeated doses that we prolong the sedation of the patient. So what are the most frequent indications? I think the solid pancreatic lesions is one obvious indication. And we have the adenocarcinoma that is usually hypoenhancing, or it has a washout. We will look at this. Neuroendocrine tumors typically are hyperenhancing in arterial phase, and then maybe this stays or they become isoechoic. And then focal pancreatitis is often isoenhancing. For pancreatic cysts, it can be very useful with contrast. Is there echogenic content in the cyst? Does it represent debris, or is it a vascularized nodule, which is a worrisome feature according to European guidelines? Is the contrast uptake homogeneous around the cyst, or is there maybe a sign of a tumor tissue around the cyst? And then for intramural lesions, it has been used for irregular vessels and perfusion patterns, and I will show you an example of this. And the new and perhaps very exciting indication is to use EUS contrast when you use radiofrequency ablation. Then you can use it before and after the ablation, and particularly with neuroendocrine tumors that are often hyperenhancing. It is very useful to see if you have ablated the whole tumor volume adequately. And I will end with showing you one example of this. So how do we use it? We use imaging with perfusion to show vascularized tissue that we are not able to do with Doppler methods. And we use the bolus method with a low MI in the arterial phase, which we define as 0 to 30 seconds after the first arrival of contrast, and then the venous phase that is after 30 seconds of the arrival of contrast. We can also make use of the contrast in the B mode image with the color Doppler after the injection of contrast, as the color Doppler or Power Doppler is sensitized very much. We have to be aware that then we use a higher MI and we are destructing the bubbles in the imaging field. So let's go to the first example of a solid tumor in the pancreatic head. So this is a female patient of 58 years with a tumor in the pancreatic head, and she comes to endoscopic ultrasound. And we see that we have this tumor here. I hope you can see my marker. And you see that there is a kind of irregular surface or shape, and it's about 22 times 12 millimeters. And we use the color Doppler, and we have an impression that there are some vessels in this tumor, but there are more vessels in the surrounding tissue. And if we turn up the gain a little bit, maybe we have some artifacts, but this reinforces this impression that there are less vessels inside the tumor. We also we are using elastography, and we get a clear impression here that this tumor is harder than the surrounding tissue. And we add up these different features of this tumor. And now we will start the contrast, and you will see as the contrast arrives, we see that in this tumor, which is in this area, and you see the panel on the left side is the contrast. The contrast arrives and it starts filling the tumor and the surrounding area. And what we see is that after about 16 to 20 seconds, this tumor become nearly isoechoic with the background. perhaps a little hypoenhancing still, and then after that it starts to wash out. So as we reach 30 seconds or even before that, we see that this tumor area here is already starting to get darker, and we can follow it a bit further into the venous phase, and we still see that it becomes even more distinctly washed out towards as we reach up to a minute. So in summary, tumor diameter of 2 to 3 centimeters, it's hypoechoic on B mode, it's hard on strain elasto, and it seems to have few vessels. So we already have a strong indication that this is a malignant tumor. With contrast-enhanced EUS, we see early uptake of contrast to nearly iso-enhancing less than 30 seconds, and thereafter we see a washout. And at 36 seconds around that time, we see clearly a hypoenhancing, which is, and these are typical findings for adenocarcinoma. It was done in EUS FNA with a thin needle, and the cytology showed malignant cells, and it was ductal adenocarcinoma. And furthermore, this patient was treated with Whipple surgery and removal of 3-centimeter tumor in the pancreatic head. The surgery was radical. There were no lymph nodes, and the pathological stage was T3 and 0. Okay, so I'll move to another solid tumor in the pancreas. This is a non-functional PNET, pancreatic neuroendocrine tumor of about 20 millimeters in an 82-year-old male. We go first to the B mode and we start the color Doppler. And we see the feature of vessels that are surrounding this tumor in a way that we call a basket sign. We have a basket of vessels surrounding the tumor. And we also see that there is a small black spot, which is a cystic area within this tumor, which is not unusual for neuroendocrine tumors. And now we go to the contrast, and you see the contrast is now arriving, and it starts to fill the tumor. And this tumor is behaving very differently from the last one. After some seconds, we have a very clear filling of contrast in the tumor. We see the cystic area even clearer. We can even see some small septations within this little cyst. And this contrast seems to stay, and then it evens out. This was not part of this video, but we see a very clear contrast filling. We can also use what we call the accumulation mode. And when we start this, we stack the images on top of each other, and we see that this constant movement creates some blurring of the edges of the tumor. So we have to, that is one of the problems of being close to the heart. Okay. So there is a study I just want to refer to by Kitano and co-workers. That's the characterization of small pancreatic lesions with contrast-enhanced EUS compared to multi-detector CT and EUS FNA. And they included 270 consecutive patients with pancreatic solid lesions that were detected on conventional EUS and they went to contrast-enhanced EUS for evaluation of vascularity. And the aim of the study was to compare contrast-enhanced EUS to other modalities of CT and EUS FNA to differentiate ductal carcinomas from other solid tumors. And on the basis of the contrast-enhanced EUS, they categorized the lesions into 4 categories. The non-enhancing lesions that would typically be a cyst, the hypoenhancing lesions that would typically be adenocarcinoma, the iso-enhancing lesions that would typically be an inflammatory lesion, and hyper-enhancing lesions that would typically be a neuroendocrine tumor. And in the results, they found a very high inter-observer agreement. They had a kappa coefficient of 0.94 for reading these images between observers. The contrast-enhanced EUS category hypoenhancing diagnosed ductal carcinomas with a sensitivity of 95% and a specificity of 89%. And for diagnosing small adenocarcinomas less than 2 centimeters by contrast-enhanced EUS, the sensitivity was 91% and the specificity was 94%. The contrast-enhanced EUS depicted hypervascular enhancement, diagnosed neuroendocrine tumors with a sensitivity of 79 and a specificity of nearly 99%. And when contrast-enhanced EUS was combined with EUS fine needle aspiration, the sensitivity of the fine needle aspiration increased from 92% to 100%. So let's move on to the cysts. I think cysts are one indication that where contrast can be very useful. And we see the B-mode image on the left and the contrast image on the right. And we've already reached the time when the contrast has arrived. So we see some fine septations in this cyst. It's a kind of a complex cyst, about up to nearly 4 centimeters across in the largest diameter. And we look for small nodules in the wall of the cyst. And we see that it's a good correspondence between the B-mode image and the contrast image. And we do not see any nodules. We also look at the area around this cyst, and we see on the right side of the image, it's a bit darker, but we see that here is a vessel, and we see that there is a contrast in this vessel. So we don't have to worry about this area on the right side in the screen, which is a little bit darker. So that was used for exclusion of pathology here. And now I will move on to, yes, this is the same cyst, but now we are gone back and we look at the color Doppler. So we can see that we have a very sensitized color Doppler. So we can turn down the Doppler gain very much and still see vessels very much. So that's an add-on that can sometimes be useful. Okay. So now I'm going to show you a different cyst. This is a very complex cyst with some thick septations and nodules. And you look at the left side here to see the contrast is just arriving in an artery here. And we see the rim of a cyst. And we see that in this cyst, there are some septations too, but these septations are very thick and they are vascularized. And in a while, we will see in this area a small nodule that is connected to one of the septations that also takes up some contrast. So this was more worrisome features of this cyst, and it was later operated. It was an IP&M tumor. And then I will show you one case of an intramural tumor. This is a male patient, 70 years old, with an intramural lesions in the stomach. So we get the answer already. It's a GIST. It was surgically resected, and it had 8 mitosis per hypoer field. And we will see how it looks now with contrast. So we soon see that the contrast arrives on the left side, and we see that it fills, and we already see that the echogenicity of the B-mode image is irregular. There are some cystic areas, and these cystic areas can be seen even clearer with the contrast. And we also see that there are solid areas that are hypoperfused compared to other. This can help us guide the EUS FNB as we would use in this lesion now. In some cases, you may be, if you see this pattern, there is maybe be a good reason not to puncture and just to send to surgery. So there is also a study looking at intramural tumors in the stomach. And this study included 76 patients, but 29 of them went to resection. And that's, of course, a bit of a tip of the iceberg. There's the most suspect lesions. And 16 of them had low grade and 13 were high grade based on the mitotic activity postoperatively. And the abilities of EUS-guided EUS FNA and contrast-enhanced EUS to diagnose the malignant potential were compared. And the sensitivities with which CT, power Doppler EUS, and contrast-enhanced EUS detected intramural vessels in high-grade malignancy and GIST were also compared. So we shall look at the results. The contrast-enhanced EUS identified irregular vessels and thereby predicted GIST malignancies with a sensitivity, specificity, and accuracy of 100%, 63%, and 83% respectively. And EUS-guided FNA had a sensitivity, specificity, and accuracy of 63%, 92%, and 81%. So we see that this number, 63%, is repeated in both, but for the first, it's for the specificity, and in the second, it's for the sensitivity. But of course, the accuracy is affected. And contrast-enhanced multi-detector CT, power Doppler EUS, and contrast-enhanced EUS detected intramural vessels with high-grade malignancy GIST with different sensitivities. And for the first two modes, it's quite low, and the most sensitive one was the contrast-enhanced EUS. So these are selected patients. We have to think about that. So in the next video, it's a combined video, so I will prepare you for what you're going to see. You will see the EUS color Doppler first, demonstrating a basket sign of an insulinoma. And then we will see contrast-enhanced EUS with a weak hyperenhancement. It's much less than you saw in the first demonstration of a neuroendocrine tumor. And then if you look well, you will see a stent in the pancreatic duct that is already placed there prophylactically to avoid procedure-related pancreatitis. And then we will see the EUS-guided ablation. It's repeated twice. And then we look with contrast to see if we've ablated the full volume. And we think we have not, so we make a third re-ablation. So, you ready? I will comment on the way, sorry. It's too quick. So now we look at the body or the neck of the pancreas, and we see a dark lesion here, and with the color Doppler, especially this fine flow mode, we see that there was a basket sign. And now we move to the contrast, and you see the lesion in this area. And the lesion, at least the left side of the lesion, is hyperenhancing, but it's not so homogeneous throughout this lesion. So it's mostly on the left side, and it's less than we saw previously. So now we have put the ablation needle into this lesion, and we ablate until we see the formation of bubbles like this. We shall see that we move the needle a little and repeat this procedure. And now we will use contrast again to see if we have ablated the area. And here we see when the contrast arrives, we look through the volume, and we seem to have an ablated area here. And we are not completely happy with the full volume, so we seem to have a small bit. So we insert the ablation needle once again, and we repeat a third ablation in this area where we still could see some contrast. And here is the formation of bubbles. it completes this ablation. And after that, we again apply some contrast to see if the area is now fully ablated. Yes. And here you see the stent already, because if there is less than 2 millimeters from the lesion to the pancreatic duct, we put a prophylactic stent. And now we use contrast again. We see the contrast here in the vessel, but the ablated area is in this area. It's not that clearly demarcated in this these images as in the first. And we also reapply this. Now we have the accumulation mode, and we see that the ablated area is darker, and we still have these artifacts from the movements that I mentioned earlier. So in summary, applications of contrast-enhanced EUS. Solid pancreatic lesions with contrast-enhanced ultrasound have characteristic contrast patterns. The adenocarcinoma is hypoenhancing, neuroendocrine tumors are hyperenhancing in the arterial phase, and then hyper or isoenhancing. Focal pancreatitis is usually isoenhancing. For pancreatic cysts, you can demonstrate in the cyst wall nodular lesions with contrast and septations, and we also look at the area around the cyst to see if they are part of a tumor. And for the intramural lesions, we look for irregular vascularity, and this may indicate higher risk lesions. And for EUS-guided radiofrequency ablation, we look for the lesions before and after ablation to visualize complete ablation in hyperenhancing lesions, and we also use contrast when the patients come back for a 3-month control. Okay, thank you for your attention.
Thank you very much, Roald, for this very nice presentation, including high-frequency ultrasound internally. And the lecture is now open for questions. Please post your questions in the Q&A box, and we can read them aloud. While we are waiting, maybe I can ask a question. Maybe you can repeat for those who are new to EUS how you can and how you should apply the dosage of contrast-enhanced agents in relation to the high frequencies you are using.
Yes, I think we had a lecture this morning about this, and I think it's a line of how you mix the contrast, how you prepare it and shake it, and that you should have a large arterial, a venous line is always better than a small one, because you have to pay attention to that you are injecting bubbles, very delicate bubbles, and you must have no filter or anything on your IV line, and this should be done in a slow motion so that you don't destruct bubbles too much. But the general impression with EUS working with higher frequency is that you see a smaller fraction of these bubbles. So it means you need to apply a higher dose. So very often with Sonoview, we apply a full vial. If we use Sonazoid, we can use maybe half a vial because we have an impression that maybe these bubbles are resonate better with this frequency. But I can't go into technical details about this, but it's an impression we have.
Okay, Roald, thank you very much. There are no more questions in the Q&A box, so thank you very much for an elegant lecture.